Welcome to the first of 5 short topics to help you participate in the ICE initiative by CLMA. ICE, you may know, stands for Increasing Clinical Effectiveness, and it's a result of CLMA's strategy to try to engage the laboratory profession in shifting from a focus on operational efficiency to a focus on clinical effectiveness. The goals of ICE are to catalyze efforts to improve clinical effectiveness, to bring increased attention to the linkage between laboratory services and patient outcomes, and to disseminate best practices throughout the laboratory profession. Last year, we gave an hour-long webinar on ICE, and that is still available at the ICE website, ice-lab.org, or through the CLMA website. And you can get it under resources, and if you haven't seen it, it provides the rationale and the business case for the shift from focusing on productivity and cost in the lab to what kind of a difference are we making for patients. Now, to get a very powerful ICE initiative, it takes quite a few steps in terms of conceptualizing the project and implementing it. And so in these mini webinars, we will go through the various steps, giving you a little more information about how to have an effective program. Today, we're going to focus on choosing a quality improvement initiative that will link strongly to patient outcomes. Now, in traditional QI problem selection process, just think about how you come up with your ideas. A lot of times, you're examining rework. When do you have to go out and recollect samples? When do you have to redo a test? Exception handling. These are various obvious ways for a literally factory approach to laboratory medicine. It's all internally focused. Another way of looking at what projects to work on is through financial variances. Where are you going over budget? What tests are driving your budget expenses in certain directions? Where is labor causing you budget problems associated with rework? And then, of course, we respond to complaints, and the complaints tend to come from physicians, patients, or the administration. And finally, we look at our own internal metrics, quality and productivity. It could be FTEs required to get a certain volume of testing out. It could be unlabeled vials or short fills or hemolysis metrics that we track. But these are the ways we typically come up with projects that we can pursue. The trouble with them is they tend to be very lab-centric. Even the response to complaints, the reason those complaints come to the lab is because it's felt that there is a problem inside the lab that can be worked on. And so they are lab-centric, but they are not test-centric or testing services-centric. And in this move from fee-for-service to reimbursement for value, we want to always concentrate on being patient and value-oriented, not lab-specific. So a different approach, I think, can be very appropriate. One is focusing on patient value. And we'll talk about these in a little more detail, but we really are talking about improved satisfaction, improved outcomes, or reduced harm. And that's particularly important because improving outcomes can be very difficult to measure inside the laboratory. Time to diagnosis, time to wellness. Those are great patient outcomes, but very hard to measure. But harm can be more easily detected. And that's why it becomes, the avoidance of harm becomes a very important issue for us. We can also look at system values. So what are the economics to the system and the strategies that the system is pursuing, and how do we align to those? Now, as you think about the various projects, the criteria for selection are probably the same, whether it's in the traditional approach or in the patient value approach. First is, what's the importance and the impact? In a traditional perspective, you may be thinking especially about the importance or the impact in the lab. But now this question is, what's the importance or impact to patients? Or what's the importance or impact to the health system or the population? So that's where it all needs to start. And thinking about where the problems occur and how testing impacts those problems is a great first step. Then is, do you have an idea of how you're going to fix the problem? So an intervention. It's got to be likely that it might work. You've got to have a strong hypothesis, a rationale for thinking your intervention might work. It also has to be feasible. If it's going to take $10 million to implement it in 5 years, it's probably not likely that you're going to get approval or you're even going to choose to pursue it. The same if it involves changing the electronic medical record system of your hospital or health system. So feasibility has to be considered early on. Then, especially when we're thinking of outcomes, the outcomes, as I said before, are generally not based solely on what happens in the lab. And so we have to start thinking about who else will be needed on the team. And can we get their commitment? If you need nursing, if you need physicians involved in the team, if you need patient safety or risk management involved in the team, will you be able to get their support? Is your rationale for this project of sufficient interest to them? And will there be issues around scope of work or authority issues? Generally, I always say, if you can think of what's true north, and if true north is patient outcomes, it's hard for people to argue. You can argue about priorities, but you can't argue about whether something is important. So someone else may have a problem that has greater patient impact than yours, and that will be prioritized at a higher level. But if you have a project that will impact patients, and significantly, hopefully you'll be able to enlist, and you should try to enlist the support. We can have an entire session on the art of collaboration, and in fact, we hope to bring such a presentation to you in the future. Then again, what resources will be required? These can be financial resources and people resources, and will you have them? And then what data are you going to need to characterize the problem? Certainly measuring the problem, you know the old adage, you can't manage what you don't measure. So you need to be able to envision how you're going to measure the outcome, and therefore how will the intervention you're considering link to that measurement? Will the implementation of the intervention produce a corresponding change in the measurement? If there isn't linkage between the intervention, the measurement, and the outcome, that's going to be a problem. Now, we are going to have an entire one of these short courses devoted just to the issue of measurement, as well as interventions and methodology. So we're not going to cover that at this time, but certainly one of the things you need to consider. And then finally, will the outcomes that you achieve be sustainable? Because no one wants to invest energy in a project that as soon as you take your eye off the ball, things go back to normal. So you have to be able to address the issue of sustainability. Purposefulness in selection is certainly critical to a successful project. Now, I'd like to focus a little bit more about testing-related patient harm, because that should be where you go to determine sources of QI projects. As I said, we can control the harm we do, and by analyzing that harm and measuring hemolysis, measuring unlabeled vials, those things have the potential to cause harm, but they don't by themselves cause harm. I wrote an article a couple of years ago that defines a taxonomy for testing-related patient harm. And my hypothesis that is still standing up after a couple of years is that all patient harm related to testing fits in one of these 6 categories. The 6th one is an addition that I came up with later because it's focused on iatrogenic harm, going out and sticking someone a second time. Or if you're in imaging, it's the radiation damage that it may cause. But those first 5 ones are the ones we should be thinking about. An inappropriate test is ordered, an appropriate test is not ordered, an appropriate test result is misapplied, an appropriate test result is ordered, but a delay occurs somewhere in the total testing process, or the result of an appropriately ordered test is inaccurate. That last one is the only one that's within the control of the laboratory. Even the 4th one is a shared one if you look at the total process from when the doctor envisions the order and orders it to when the physician retrieves the result and applies it. The portion that occurs in the lab is only one small portion. And I would argue the first 3 really are about things happening away from the lab. But it doesn't do us any good to turn out an accurate, timely, low-cost test result if it's the wrong test, or if we aren't turning out the right test results for the patient needs. So key question here is, do you know how your system performs? How is inappropriate testing defined and measured? Do you have a way? Is anyone coming up with a way? How does your system measure failure to order appropriate testing? How do you, meaning your system, know when the order to result application has been inappropriately delayed? How does the system know if a test result has been retrieved in a timely fashion? And how do you know if a test result has been interpreted appropriately and applied correctly? In future sessions, we'll talk about how to do some of these things, but that's the key. If you're looking for a project to do now, which of these things can you address? Here are some typical problems that are ripe for investigation. Failure to follow up. What if an abnormal test result is issued and a repeat test, maybe in 30 days or 90 days, is called for, but it never shows up? Just by going into your IT system, you can look for the presence or absence of that repeat order. Are there appropriate and expected follow-on tests based on an out-of-bounds or abnormal initial test result? You should be able to look for that cascade, and if that cascade doesn't happen, that may be a result that wasn't retrieved. It may be a result that was inappropriately interpreted. You may not want to react to every instance of that, but looking for patterns or looking for numbers of those things are a great source of potential quality improvement projects. I don't have time to go through all of these individual ones, but you can see here some of the other ones that people have used. And if you're pursuing a system strategy, such as readmission or patient satisfaction, think about the test results that impact or potentially can mitigate this risk of readmission, as an example. If we look back to the one sample, the tests or the submissions that were winning submissions in 2014, we had 4 that were given orally at the CLMA Knowledge Lab. There was one on implementing the test utilization program. There was one on reducing transfusions and the units per transfusion. There was one on using increased MRSA testing to decrease length of stay and cost. And there was one on reducing post-op sepsis, which was very innovative. It was done in a physician lab, and it was a PLO. And they did susceptibility testing, drug susceptibility testing in advance to determine what prospective antibiotic would be administered during the operation or in advance of the operation. So these are examples, and we will hopefully have these posted on the website very shortly, so you can look at the presentations as well. In this series, we will have the one that I'm just concluding, choosing the right problem. There will be one coming up on choosing the right measure, one on the right methodology, one on collecting and analyzing the right data, and one on writing and submitting the winning abstract. This will be a great opportunity for you to bring value to your system and to bring value to your profession. Let me wrap up very quickly by saying QI problem selection needs to be very purposeful with a well-defined rationale for the project, and that rationale cannot use traditional mechanisms of cost or productivity waste that is solely in the laboratory. We have to take a very broad context to it. It's got to make a difference for patients or at least align with important health system goals. And to be successful, the project must be collaborative from the outside, ensuring the right support and the right team. If you start out with this approach, you'll have a project that ultimately has the potential to deliver real value to your system and to your patients. Thank you, and I'll look forward to talking to you again in the second session.